Today's episode brought to you by Owens Recovery Science, a single source for PTs who want to add personalized blood flow restriction rehabilitation training to their clinical practice. Get certified at owensrecoveryscience.com. The all-in-one outpatient PT EMR built on automation. That's Empower EMR. They empower owners, physical therapists, billers, and your front desk to profitably provide the best possible patient care experience. Find them online at empoweremr.com. That is empower.
What I see is therapists getting really stuck and narrow in their thinking about, to no fault of their own, truly, but thinking narrowly about what's happening within my clinic and those walls and what I historically have been able to control or change about that piece of the healthcare pie that I live in. But the big picture here, and I try to encourage everyone, therapy or anywhere else, to think about it this way, is healthcare spending is not, it doesn't make sense. It's not, we're spending more and more. We're either getting the dollars through insurance premiums or through taxes when it's Medicare taxes, or if it's states for Medicaid. And there's not enough money to keep up with the spending, and we're not getting good outcomes for that spending. And that is just a fact. We are the bottom of the barrel when it comes to health outcomes for industrialized nations.
Today's guest is someone who's working to change how healthcare is paid for and delivered, not just on the front lines, but in the policies that dictate how we value care. Dana Strauss is a doctor of physical therapy who's built her career in a world of public policy, becoming a leading voice on value-based care and Medicare policy. As the Senior Director of Government Affairs for CVS Health, Dana is at the forefront of efforts to reform healthcare incentives and ensure that healthcare dollars are being spent more effectively. She believes that value-based care is the future of healthcare, and it's something physical therapists cannot afford to ignore. If PTs want to be part of the healthcare teams that are driving the most significant changes in care delivery, they need to understand the policy landscape, like it or not. They have to prove their value to payers too, and collaborate with primary care providers. In today's conversation, we get into with Dana. She'll take us through why value-based care matters and how physical therapists can position themselves as vital players in the evolving healthcare ecosystem and what steps they should be taking to secure their role in the future of healthcare delivery. We even wrap up with a little bit of a challenge, sort of prompted by me, but I was a little inspired. And maybe I'll be taking my voice to CMS if you want to come too. Stay with us. This is PT Puncast. Dana, welcome to the program.
Thanks for having me, Jimmy.
All right, so we're doing an episode on value-based care, VBC. Mm-hmm. So we got to start from the start. For people like me, make sure I don't get left behind. Mm-hmm. Help me understand. Explain what value-based care is, and then why is it such a game changer for healthcare, especially for our colleagues who are also physical therapists? We'll start with the macro.
Yeah, we'll start big macro. So I'm going to define it two ways. So, because I think value-based care is just a buzzword. I hear it thrown around and really without an understanding of the context. And I break it down kind of into two parts. There's the care part, what's different about the care, and then there's the payment model part. Okay. So when we say value-based care, it can be as simple as I'm providing care that's valuable, that leads to something that's a better outcome, and the dollars were useful to that individual and to that person's long-term outcomes. And then there is value-based care in sort of the greater alternative payment model sense, which means that providers are reimbursed for the care that they provide based on the outcomes of the individuals they provide care to. And that's generally at the population level or at the episode or group of episode level. So value-based care essentially means that you're providing care that is the highest quality for the lowest cost. So it's an equation, right? At the simplest terms, it means like looking for the best outcomes, providing the best care that leads to those outcomes, and avoiding unnecessary care, right? That's part of value-based care. Providing more upstream care, providing, avoiding care because you're providing higher quality care on the upside, managing chronic conditions better, so you're avoiding the care of complex patients that you can do better on. It's all of those things. That's really what value-based care means.
Got it. Now, why is
Mhm.
it such a game changer? Why is this
Mhm.
going to be better? Why is this something that we should do more of?
Yeah. So what we've been doing up until now is very broken, right? In America. In America, we pay for care based upon the amount of care a provider or an institution can get in a day, right? Or get in an episode. So when we're talking about, like, let's say a physician office, kind of use it as the gold standard, it's how many visits at high unit price can you get done in a day?
Right.
If you're talking about a hospital, it's based upon the payment that the hospital gets for that admission. How quickly can we get that person through the admission and discharged to fill the bed again? So everything is based right now not on the product. I call it the product, the outcome of an episode or care that's provided, but it's based upon the quantity. And when we move to value, we're looking at care completely differently. And that includes even things like what we consider worth paying for. And so we'll move into why that's important to therapy after giving you a little bit more of the background. And I'm going to use primary care as an example. So primary care docs, primary care providers, when you think about physician practice, traditional primary care, they're doing a lot of things that don't have reimbursement codes, right? And a lot of what is highly valuable in medical care doesn't have reimbursement codes because we developed the reimbursement system based on only transactions. So a primary care doc, ideally, their whole team is working on maintaining engagement with their patients, getting in their annual wellness visits, making sure they have their colonoscopies done, making sure they have a strong way to communicate with the office when there's a problem, making sure they have really good access to care, having time with patients. None of those things have reimbursement attached to them, right? Like having good access hours, that's not attached to anything. Being able to spend additional time with people to explain how things work rather than sending them right to a specialist, no reimbursement around that. Addressing people's needs for food, housing, any of those things, social determinant issues, there's no reimbursement codes for those times. So when the simplest way to think about as I start to bring in the role of PT, is where you have care, providers that give care, provide care, that revolves around a lot of communication and behavior change you're trying to help with or incentivize. You have an opportunity to look at the value of those services differently in value-based care. And I'm going to segue that into therapy here because, as we know, as physical therapists, and your listeners know, there is a lot that physical therapists do and the therapy professions do that does not have either a high value associated with it or any value at all. So when for example, we spend a lot of time on patient education, right? And we work on helping to change behavior so that patients follow their home exercise program, which may then involve a longer and a better long-term outcome. Those don't have billing codes attached to them. So
Right.
we have a certain number of billing codes associated with therapy. They're transactional in nature, and they only have a certain value attached to them based upon the RUC, right? So if anybody's not familiar with it, I always have to look at it so I make sure I get it right. The Relative Value Scale Committee, or they call the RUC, determines the value of our codes. So therapists don't have a lot of codes to choose from in outpatient care. There's not a really high value associated with those codes. And there are lots of other things that they do now that there's no reimbursement for.
Right.
And they're constantly on this treadmill of figuring out how to increase volume. There's only so much you can increase volume and still provide good care, and somehow achieve a different level of reimbursement over time. And if we can look at how primary care providers, and I would argue therapists belong on primary care teams. If we look at how primary care providers are using these new payment arrangements to take the other things that they do as a team to add value to patients and to the payers who pay for the care, if it's not patients themselves, then we have a whole new opportunity that we haven't even considered yet for what could be next. Let me stop there.
Well, I was gonna say it. I mean, when you say it like that, and we've seen it before in practice, I don't think I needed to be a seasoned PT to realize I was de-incentivized to get someone better faster. Like you said, there's not a lot of codes for the other things that we did. So keeping someone around who I could charge a code for a longer amount of time I was de-incentivized to do the opposite of that. So it feels like nobody wins in that situation. We're all it's a race to the bottom is what it feels like.
No one wins. That's honestly what I think from the start of treating as a therapist drove me crazy.
Right.
None of it didn't make any sense. Like I would know inherently that I didn't need, if I could bring someone in, give for a great evaluation, do a follow-up, do teaching, I could probably go a week with just a call in between to make sure they were following that program and then bring them back in for the next assessment. And there was no way. That doesn't fly in fee for service, right?
Correct.
It doesn't exist.
We hear horror stories from new grads talking about, this is how we've always done it, or some people even being terminated or just being made, to have a really bad environment if they went about it in a way that didn't keep someone coming in frequently and for a long time.
You got it.
All right. So you've now that we sort of understand value-based care, right? And why it's maybe a better idea than what we're doing now. Why is this crucial for the future of healthcare? It feels like when we start to talk about even more bigger macros, not just a profession, but the healthcare environment, if things continue this way, bad things will happen. Things might just collapse. Am I right?
Yeah.
If you work in outpatient PT, you interact with your EMR a lot. You deserve to have an experience that's seamless and integrates all the things you might need to do, like a patient portal, marketing automations, and billing, all in one, all at an unbeatable value. That's what MW Therapy does. Switching over is a breeze. Take a test drive right now and see what you could do with them at mwtherapy.com. And where's your PT career license taking you? Get a driver's license. You can drive wherever you want. If you're a physical therapist with a license, you can provide physical therapy wherever you want. That's what Jackson Therapy Partners is there to do. Extraordinary patient care adventures with Jackson Therapy Partners. Perfect for PTs eager to make their mark. Do what you want to do, where you want to do it. See where your skills can take you at jacksontherapy.com. And if you've heard about this thing, we've had it on the show before. It's called remote therapeutic monitoring. And it could boost your clinic's revenue and help more people. Those two things are good. Find out how Physiotech can help you do that. That is Physiotech at their website, physiotech.ca. That's physiotech.ca. Maybe boost your revenues, your clinic's revenue by $290 per patient per quarter now with Physiotech.
If anybody listening went to the University of Scranton and had Dr. Gary Mattingly as a professor, he was the anatomy professor. We had him for many classes for many years. Unfortunately, died prematurely of brain cancer, maybe 5 or 10 years ago. He used to say, and I took this everywhere I went, he used to say, just make it make sense. When we'd ask him questions, before he would want us to find the answer, he'd say, make it make sense. And I think that's part of what we should be thinking about as therapy professionals. What I see is therapists getting really stuck and narrow in their thinking about, and to no fault of their own, truly, but thinking narrowly about what's happening within my clinic and those walls and what I historically have been able to control or change about that piece of the healthcare pie that I live in. But the big picture here, and I try to encourage everyone, therapy or anywhere else, to think about it this way, is healthcare spending it doesn't make sense. It's not, we're spending more and more. We're either getting the dollars through insurance premiums or through taxes when it's Medicare taxes. And or if it's states for Medicaid. And there's not enough money to keep up with the spending, and we're not getting good outcomes for that spending. And that is just a fact. We are the bottom of the barrel when it comes to health outcomes for industrialized nations. We're the worst, right? We have the high infant mortality. We're actually coming down over the course of time. Plateauing, but we've come down, and we're nowhere near the age life expectancy of European countries in the mid 80s.
Sure.
We're not doing a good job with all of these dollars we're spending. And there's a breaking point, right? It's not sustainable. So when I think of Dr. Mattingly and make it make sense, what makes sense is to reimagine how and why we reimburse for care. What care is valuable? What should we be incentivizing? And everything related to how we deliver care is based on incentives. To your point before, 3 times a week for 10 weeks, whatever, right? It's because there's the incentives present to do that kind of volume. And if we don't reimagine, and we know there's levers we can pull, they're being pulled already. If we don't reimagine healthcare delivery and healthcare spending and how it's done, there's no other solution, right? That I can imagine. And I've tried imagining solutions. So which providers, this is where therapy comes in, and why I am really eager to get this message out as much as I can, is which providers are really well suited to make a difference in value-based care and in healthcare transformation, because a lot of what they do doesn't have either high enough reimbursement or reimbursement that makes sense for the total value they're providing to individuals and populations over time. Now, we know, like primary care docs, a lot of the incentives are being driven to primary care teams, and we can get into that more. But behavioral health providers have done a great job of acting on this. Over the last 5 to 7 years, they have accomplished a lot of what they have intended to do, which was to position themselves as really highly valuable members on primary care teams. And there is a void in those primary care teams. We have physicians and APPs, we have behavioral health, and then we have a void for musculoskeletal, neuromusculoskeletal mobility care, where docs and behavioral health providers on those teams cannot manage these patients well themselves. Sure. They will actively admit that, right? But we're not there. Right? Our profession is not sitting at the table, and we're not even, that I see generally, having these conversations. We're not even aware they're happening overall because of being used to being in our own place generally.
Sure.
And so our value as therapists is so much greater than what we're being reimbursed for, but the profession itself has to move itself forward and demonstrate its values to other healthcare professionals and policymakers before it can achieve the value that's really available to it, right? In terms of what you can provide to populations of people.
All right. So this
makes sense.
You're making it make sense. So this is a PT talking to PT with a bunch of PTs listening, which is great. So of course we're going to agree. Everyone's nodding. I'm watching you at your car right now, driving and listening to this episode. Even you're nodding. But here's the thing. What practical steps can we actually be doing so we as a profession can demonstrate our value to them, this ambiguous they, the payers, the insurance system, Medicare, to make sure that they see us as integral to the care team in this thing that you just described, this value-based care system? What do we do, Dana?
Yeah. So it's a multi-layered answer. It's not here's the equation.
We wouldn't be doing a podcast episode if it was simple, of course.
Right.
So where do we start?
I mean, first, it's important to take into consideration that there's a lack of knowledge about this in our profession, about what value-based care is and what the opportunity potentially could look like. And so we have to start with just understanding some of that. How is care paid for? What models are, and payment models are, especially primary care providers participating in? And how, and this is really what, if you want to imagine the impact, like from a very high level, what's the impact primary care practices are having on reducing total spend by more dollars being driven into primary care, which is what's happening in payment models, that care being provided upstream is keeping people out of the hospital, which is reducing downstream spend. So essentially, we're trying to move dollars upstream. So understanding that component, that there literally are more dollars being given upstream prospectively to primary care practices, that primary care providers, behavioral health providers, and teams are using to care for patients upstream, downstream, stay connected, access, et cetera. Then understanding that right now, as of now, we can go to these practices, if we so choose, practices that are in these models, and say, how can we contribute to your success? Meaning, how can we be part of the team that helps you care for this population that are your patients, right? That can be done right now. We don't need any policy change to do it, but we need the awareness of where these dollars are going, who's giving it to them, and the value we can already provide ourselves.
Understood. Yeah. So can we follow not just the money? Because I think that's what we're doing now. This is follow the value. And then what money would you not have to spend? And oh, by the way, underneath this value and money conversation is getting people what they actually need, when they need it, where they need it, for how long they need it. That's actually the last thing we've mentioned in this, but should be the first thing. But that's the reason we're having this conversation. Is that's the reason that this system. So let me see if I follow. We used to run into this problem when I was a radio broadcaster in Scranton, Pennsylvania, by the way, where I used to work in radio. Wow. Good old 570 Northeast Pennsylvania. But people would say to us, "Hey, I'll give you a couple bucks if you read my script on the air a couple times."
Yeah.
And it was a transaction. You give me 50 bucks and I'll read it for 60 seconds. And the problem that we sort of started saying was, let's say Apple was an advertiser and you paid me 50 bucks and then I ran a commercial. But then that person that heard that one commercial bought a MacBook and then an iPhone and then bought iPhones for the next 25 years. What's the lifetime value of that one $50 transaction? And how do we move to more of a relationship?
That's right.
So that's what I kept coming into. This value-based care feels a lot like we're saying we're going to get into a relationship because the rising tide lifts all ships. And we're okay with that because we believe we actually provide a ton of value. So we'll get in this with you.
That's exactly it. That's where, like, if you think about physicians, they're not great. And I mean, I'm generalizing. Oh, everything is a generalization here. They're not great at communication and connection with patients. Their business has always been based on transactions. They don't excel at that. Now, primary care is better at it than most are, again, generally speaking. But therapists, physical therapists, occupational speech, behavioral health providers, even pharmacists, great at relationships with patients and building connection and communication. That is the key to success in value-based care. It is connecting with patients, building trust, offering them access to you. And in doing so over time, they're doing what you recommend and you're getting reimbursed for doing that great communication. And where we remove the transactions completely, which is what just excites me to no end, where we remove transactions is when we don't, and where therapy has to be able to demonstrate to other providers their value. That has to come first. I'll explain it. Is in when I'm going to explain this because I have to for background. I don't want to get too in the weeds, but to make it make sense. Primary care practices in particular, getting into these relationships, what they'll do is they'll say to the payer, we're willing to act like the insurance company. We're going to take on the full financial accountability. You're going to literally give us the insurance dollars, and we are going to promise, and if we don't do it, we lose our own money. We are going to manage this population better than you can by owning the dollars. And we're going to spend those dollars not by worrying about RVUs or transactions. No. We're going to make this make sense. We're going to use the data to see who's at risk, who's had historical spend, whose risk adjustment factor is very high. And we're going to reach out to these people proactively. And when they've had falls, guess what? If it's a PT on the team, we're going to bring them into work with the PT. And when they've had, multiple emergency room visits for low back pain, we're going to bring them in to see the PT. And now, when the team is just earning those dollars directly from the insurance company, and their job is to use them the best way they can so that the total spend is improved upon, there's no longer an incentive for a doc to see a patient first. And that's such an unbelievable opportunity when we can now show, listen, we don't need a gatekeeper. They don't need to see you first as the physician because they're not billing for it. They don't care. It's not a transaction anymore, right? They care about the team providing the upstream care that reduces the total spend. So now there's a great incentive if we pitch it this way, and it's 100% true. You bring a therapist on the team, you're going to reduce unnecessary specialist utilization significantly, right? Where the primary care doc, low back pain. Okay, well, what do they usually do? Send you to an orthopedist, send you for an MRI, put you on a pain medication. Instead, we're going to schedule you with the PT on the team, right? And now we're going to largely avoid unnecessary referrals to specialists, unnecessary imaging, patients going getting their pain out of control, becoming subacute, chronic, yada, 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 because we're going to address it at the right time in the right place with the right provider. Right now, we're not having these conversations. We all know this is how we can have an impact, but we're not at the table there. And again, generalizing, I'm sure there are some doing this, but right now we're not at the table. And this opportunity is just sitting there for therapists to take advantage of.
All right. So make it make sense, which feels like the theme of the episode.
It is.
Who doesn't want this to change? Because it feels like this is the right direction. It feels like this is less friction filled. It feels like this is smoother and better. And these are all positive words. So if this hasn't happened, there's a reason for it. It might be complicated, but what is or are the reasons that we're not doing this? Make it make sense.
That part, this is actually simple. It's not happening because we're not offering it right now. There is not an awareness that this is an option. And I have brought this up to primary care docs taking full risk. And what they've said to me is, that's a great idea. Somebody just has to show us the ROI. Give me the ROI. We'll pitch it, right? So this is like a provider a team taking full risk. Why don't you have a physical therapist in here? What are you doing with your arthritis pain, your patients with falls, back pain, headaches, yada, yada, yada? She said, yeah. The last conversation I had with a physician about this, she said, yeah, I know we need a PT. I'll write the prescription. I'll hope that they'll go actually make the appointment. Right. They might not be able to get to the appointment. They might not want to pay the copay for the appointment. There's a whole list of reasons why there's barriers. If I just had them right here on the team, it would be frictionless. And what they're doing now, many companies doing this, somebody with long-standing depression, anxiety, they just walk them down the hall and introduce them to the behavioral health provider on the team. Completely different. We're talking a completely different outcome when you have that handoff, you build that trust. So I would argue this is really not complicated. It's awareness first, right? And then bringing the opportunity to primary care practices that are taking risk so that we can build a better understanding by primary care, because it's where we have to start. Build it within primary care that we're here. We are doctorally trained and fully capable of helping you and your patients succeed, right? Just give us the opportunity. And I've had this question, from therapists who I've talked about this with who own practices. There's other ways to do this. I mean, being able, if you have a therapy practice that's in close proximity to practices taking risk, you can offer different ways to provide very easy access, quick communication, demonstrate a way that you can be the first and make the effort to get those patients engaged quickly if you can't put a therapist right in the practice. So there's different ways to go about that, but I would argue part of this is a cultural thing. Mm-hmm. It's how physicians perceive their role versus the role of others, and that the awareness just isn't quite there, that we have to take this step. That's what I would argue. We have to take this step before we can do anything else.
So this is a bunch of people standing around the deep end of a pool. Everybody agrees that the water looks fine, feels fine when we dip a toe in it, but we're waiting for someone big enough to jump in first, take that plunge, and make sure they don't drown.
Yeah, that's basic. That's it.
All right. So there are misconceptions about reimbursement. And I want you to talk about, many PTs are focused on the physician fee schedule. That gets talked about a lot, right? We focus on that. We wait with bated breath. We hold our breath. Help me understand this. Explain what the bigger challenge is in terms of payment and reimbursement.
So I guess I'd slightly reframe to say, it's not that it's not important. It's that it is only a component of a much bigger issue, which we touched on before, in who it is that presently decides what services deserve a code attached to them, first of all, and then what the value of the RVUs of those codes should be. So there's that piece, the volume of codes, the value of those codes, who decides those codes. And by the way, the RUC is primarily made up of specialist physicians. And then we have a chronic year-over-year problem where our spending, the physician fee schedule spending, so just for background, for anybody that doesn't know, that's anyone who bills the physician fee schedule. So that is all providers and outpatient services that are billing the physician fee schedule. They're impacted by the annual cuts to the conversion factor as a whole, but that's only a part of how the conversion factor and the updates annually impact providers specifically, meaning the conversion factor keeps being reduced, but certain providers are actually shifted more of the dollars. So like every year, if you look at the physician fee schedule, there's a list of all the specialists, and that goes, everyone that bills the PFS. And some will be +3, +4. Some will be -7, -8. I mean, I've seen -11. The weight, it's not just the conversion factor that's changed every year. It's that the weight of each of the codes that are used by different specialties, including therapists, is changed every year based upon what the value of those services is deemed to be.
Right.
So there's how we're perceived and valued. Last year, the cut was 3%. Now, you can't, it was fixed temporarily by the Consolidated Appropriations Act, which is just a one-time update just to patch they call it a doc fix, just to patch that gap. But the big problem of how we're spending beyond the budget every year, that's the bigger problem. And how do we reduce and control that spending?
I see what you mean.
We're going to do it through shifting dollars to primary care and shifting the spend to lower costs, lower centers, what's the word I'm looking for? Locations of care that provide a higher value service, right? It's not going to be these little fights of a percentage here, half a percentage here, right?
Yeah. So let me make sure I'm understanding this. What it sounds like you're saying is we're arguing over nickels and we're losing dollars.
Yeah. That's a very good way to put it.
So you're saying look bigger, look further upstream.
If you looking at primary care codes that were added the last few years, they've added something like 15 different codes, including things like community health integration codes, principal illness navigation, social determinant of health risk adjustment codes. There's been a litany. They're all for primary care, right? The idea is even a complexity code. So an E&M code for complexity of care, the idea is we're going to let primary care add on this additional payment so that they'll spend more time on a complex issue and not send the patient right to a specialist instead. Notice primary care is getting more money filtered to them, and others whose value is not demonstrated to be as high can have cuts. You have to shift the money around. There's only a bucket, right?
Okay.
So specialists don't particularly generally like the fact that more codes are being created for primary care because they're losing.
Understood.
By and large, they're losing.
Understood.
So are we being valued? Because behavioral health, who's proven their value to primary care, is seeing increases every year and more codes for behavioral health. We just have to demonstrate that value if we are to propose things like more weight to the codes, adding codes that we can provide. And then these are still transactional, right? Uh-huh. This is in regular transactional PT. Like if you're working in an outpatient clinic, this matters to you to have your codes be more valued. But that's not where our energy is really being spent from what I can see. Therapists are more focused on just the conversion factor as a whole.
Okay. So there's this ambiguous they that I mentioned
Yeah.
before, right? And you're using words like show and value. And
Mhm.
now we're starting to cross over, who knew, into my sort of area of the world, which is communication, right? But I like to understand the situation, make it make
Yeah.
sense, right? So we're
Mhm.
talking about they, so that's our audience. Always know your who. Who are they? Are they policymakers? Are they insurance company? Like, who is the they? And then I have follow-up questions. So who is, if Dana could wave a magic wand and put the one person or group in front of you that needed to hear this the most, who would magically appear if you waved your magic wand? Who is it?
Well, PT's clients are the payers, but the
Right.
payers can mean policymakers because policymakers determine the rates for Medicare and everyone else follows Medicare, essentially,
So
by
if
and
we could
large.
change Medicare, this would maybe be the largest domino, or sorry, the domino to start the line of dominoes to fall. So perfect. So now
Follow
we're
behavioral health's pattern. What have they done?
okay, good.
That's what I
So
would do.
we're going to follow a campaign that we know has already been successful. I like
Yep.
that. So now we know our who. What is important to them when you're having an advertising or communications campaign? You want to touch an emotion. I know we're
Mhm.
PTs, I know we're science, we're fact based, but we are big dumb animals, all of us, right? And I always say if you want to get someone to pay attention and spend time, you have to touch an emotion. So, what do they, our audience, we're talking about the people who decide Medicare, what do they actually care about that we could at least touch on that emotion and then slide in the back door and go, by the way, yeah, we do that. So, what is the thing that they actually care about the most, or some of those things?
Yeah, good question. Okay, so I'm going to answer that to say we're going to make the they CMS, Center for Medicare and Medicaid Services,
Okay,
because they're the ones that take the budgeted dollars that Congress gives them and decides what to do with them.
got it.
So if I were to say what's a first step that I would take if I'm, if I'm the physical therapy community and I'm looking to advocate for start with just the value, for example, of our codes or the benefits of adding additional services that would be best used by therapy, I would want to demonstrate to the Center for Medicare that we can bring additional value where they're trying to already shift value, which is to primary care teams. So
So,
I would say CMS is the first client that we
okay,
would be wanting to influence.
okay. But
Yeah.
we're gonna put a billboard across the
Mhm.
street from that committee's office,
Yeah.
right? What you could put anything you want on it, but you can't put 1,000 words because that's not how billboards work. You could put
Mhm.
like six or a picture or a combination. What is the thing? Do they want, and you can do two ideas, right? It's not just one. They want better care for less money, right?
PTs prevent unnecessary, avoidable specialty care.
Would be tough to put on a billboard, but we can get there, right? It's good to have that. We want the Miller Lite campaign. Great taste,
Mm.
less filling, right?
Yeah.
Great care at less cost. We help more people with
Yeah.
fewer dollars. We can reach more, right? Great taste, less filling. So that's our campaign, right?
Mhm.
Now, tactically, how do we do that? Because I'm not going to put Dana across the street with a billboard, right? Is this the political action committee in APTA? Is this us quite literally picking up the phone or writing emails to people? Like, this is what we hear all the time, right? APTA
Yeah.
is great. I'm a member. Flash action strategy. Everyone gets riled up. We don't know what we're getting riled up with because I got other things to do. But if you need me to do something for 45 seconds, I'll do it. Just tell me what. Make it easy. What are the tactical things? Like, how do we get great taste, less filling, better
Yeah.
care, less money to those people and actually make it change? Like, how's that happen?
Yeah, I mean, I'm going back to CMS. You have to bring awareness first. And when we say political action committee and all of that, that's focused on Congress.
Got it.
And we're going too far downstream where
Got
we
it.
first have to prove our value in from where I sit is to CMS itself. So you can, and for anybody who doesn't know, you can go online, you can fill out a form to meet directly with anybody at CMS, schedule a meeting, explain what you want to meet about, and then make your case for something. I mean, this is they work for the public. And you can schedule, you don't have to be anybody special or certain title. You can get onto their calendar, CMS, anyone at CMS's calendar generally, And depending on who they are, it could take a little bit longer. And you have to bring your basic, it's like selling. They're your clients, right? So therapists who are going to, if they were to work together and come up with what they would want, they need to show it a good reason why. CMS wants to know how anyone is going to help their cause, which is reducing unnecessary and avoidable spend. They've done that, and they feel very strongly, and many agree with them, that by changing the way we pay primary care, we're more likely to achieve the goal than in a lot of other ways. So by being able to show, again, the behavioral health playbook worked really well for a good reason. Behavioral health proved that their presence and additional codes added to that team-based care would help reduce overall total cost of care, would improve access to those services, would help vulnerable populations that don't get the care that they need be centered in that primary care hub. If I had to say right now what I would do, I would be advocating for a code for collaboration, for example, a collaboration code between primary care and physical therapy. That would be not a very complex ask, but you'd still have to demonstrate why it's valuable, right? What data can we come up with? What ROI can we demonstrate would come out of? And you can look at longitudinal benefit for patients over time. What benefit would there be to a collaborative code for PTs? They just created, it hasn't been, the final rule's not out yet, but this year there's a new collaborative code for behavioral health providers to be able to use to bill for collaboration with the provider that's providing the medical care for someone's mental health, behavioral health diagnoses. These codes can be created, right? They just have to be valued as something new can be created as long as there's a value behind it.
So you're telling me that someone like me, some Yahoo in upstate New York, could book a time with someone at CMS, because we are their boss, right? They're the government. And I could give a 15-minute PowerPoint presentation to them. Now, their job is to listen. They then decide what they do.
And ask questions.
And ask questions, right? They could do that. And then that's actually Schoolhouse Rocks. That's how the bill becomes a bill. That's how the change at least hopefully starts, or that's where the conversation is. Because us yelling about it on a PT podcast, I got news.
That's right.
They're probably not listening. I wish they were, but they're not. So you're telling me I could do that? I could actually do that.
Anybody can do that. It's 30 minutes they'll give you. And they have to hear it from a lot of sources and begin to put energy towards, okay, now we hear it. Now we understand it. Now we believe it's something that we could incorporate into the physician fee schedule maybe next year, or maybe we put an RFI out, a request for information, to see what others think about this. Besides a meeting, you can write specific letters to those who are, think about these things. But generally, you want to start with the regulators, because the regulators, the CMS, they already have the budget. They get to make decisions and proposals about new things, new codes, new services, whatever. But they're not going to come up with it themselves. And right. So, but yes, anybody can do that. You can schedule a time. There's forms you fill out online. You can bring several people. You can bring a team. There's lots of avenues. But you will get a meeting with who you would like to.
You're saying, so you said it's 30 minutes. Keep in mind, TED Talks are capped at 17. So you don't need 30 to communicate a concept or a complicated concept. You can do it in 17. I do it all the time.
Yeah.
This has now got my wheels spinning. I cared about these things, but I never really thought I would be able to do anything. But I could put together 10 slides and a coherent presentation.
Of course.
Because here's the best part too. The data is out there. The citation, so you can find this information. It's not gatekept at all. Okay, I might make a YouTube video about this. My day talking to CMS, right? Like, this is what I did and this is why we did it. Of course, do that because I think it would be fun and interesting, but good gosh, what if 10 more people did it? What if 50? What if 100?
That's what I'm, going on some select excellent podcasts, trying to share this message. You've done a great job of pinpointing it. That's a really great first step. And
let me
it
ask
does
you this,
work. It just can take time.
we didn't plan on talking about this. This just sort of came up organically, right? if we had no more than 3 meetings for 30 minutes, right? Because we need to keep this a realistic ask. This can't be the next crusade for the, Holy Grail for you and I, because we just met 41 minutes ago when I pushed record. What I would do is I would act as your de facto marketing department. And I would say, we're going to put together no more than 10 slides. And we have to tell a story in those 10 slides or less than 30 minutes that clearly communicates one idea to try to plant the seed in whoever's listening to us. And we might need to do it for the next 5 years, right? Once a year for 5 years or 10 years. But I would love to do that with you because you're the brains and I just know how to use Canva. Let's be honest with you, right? I can use sound effects and I can make it sort of fun. But we'll document that process in public, and maybe 3 other people will do it. Let's keep our expectations real, right? Hundreds of people listen to this podcast, right? But actually getting someone to do something is a little trickier than that. Otherwise, we wouldn't be having this conversation. But the goal would be to get 3 other people to do 30-minute presentations with CMS. I feel like that's a realistic, and we're PTs, so we like to set realistic goals. I would do that. I would spend 30 minutes times 3 with you and then do it, right? And then actually get on the books. Because I don't know, that'd be kind of a cool thing to be able to say you did. I spoke to CMS on behalf of physical therapy. I mean, I'm blushing a little bit just thinking about it. So if you help me, I'm in. I'm 100% in. And we can record this process. They called it building in public, which is we could record our meetings, right? Chop them up into segments, right? Condense a 30-minute meeting and down to 3 minutes and go. At the end, I'll share the slide deck online, and then we can record a dress rehearsal before we do our call. You didn't think you were going to get homework on this podcast, did you? So think about it. I won't put you on the spot because we're recording. So are you in? Okay, great. Don't think about it.
And I do this. So just to kind of, because I mean, give really an intro to sort of what I do. I don't get to talk about physical therapy at my day job. I'm working in public policy for a large publicly traded company, and I get to work with and meet with these regulators, and it's not as hard as it sounds like it is. You do have to have a good argument or a good presentation. They're really smart people who want to understand without it being complicated how they can see value in it and how it fits. And this is the key. How does it fit in what they're already thinking about and what their plans are? You can't make them think about like pulling things out of a hat that don't make sense to them.
Right.
But which is where this comes full circle to awareness by therapists. Like, how many therapists can say, I know what has CMS's goals been in the number one payer in the country? What are CMS's goals for the next 5 years? They've articulated them, primary care strategy, specialist. They articulated them beautifully in health affairs. Does anybody know them? Because if you know them, you then know what's going to resonate with them.
Yes.
And you can make an effective, argument, but really you're selling a concept that they has to resonate with them and help them. Everyone wants to achieve that. How can you help me?
Correct.
They're just going to want to know, well, that's great. How can you help me? And by me, I mean, how can you help us reach our goals?
That's why I asked you, what is the emotion that we could put on a billboard that would at least get them to read it and go, huh? Dana, I already know the title of our presentation. Do you want to know what it is?
Go ahead.
Make it make sense.
Where'd you get that great phrase?
Listen, themes emerge. That's how magic works. Dana, last thing we do on the show is called the parting shot. This is just your last chance to sort of have a mic drop moment. You can repeat an idea you've already had, something new, whatever you want to do, a quote, a feeling, an emotion. What would you want to leave the audience with as we wrap up this episode?
Give me just a second to think. And I know you already prompted me on this, and I know you can edit. So, so I mean, not to be too controversial, but maybe I'm going to just mention what frustrates me right now and why I'm willing to stick my neck out, even though sometimes I think therapists look at me like, you're not on our side. Maybe it's a call to action, not a mic drop. And the call to action would be pan out. I write about this on LinkedIn kind of frequently. Therapists, if we're going to do any of these things as a profession, we need to pan way out and realize that we are mainstream medical professionals, right? I went to school for PT because I realized it was a mainstream medical profession. Yet we're largely living in a world in our own. I mean, we have referral relationships and we work with other providers, but we less than we should think, how do I fit in? And how can I be a closer collaborator and team member and how can I demonstrate my value to those providers that are incentivized to care? And I would encourage therapists to understand much better about incentives. Why do people do what they do? Because I read a lot about, well, they should just understand this, right? Like, why don't they get it? Because everyone is driven by their own incentives, and incentives are created in a lot of different ways. In healthcare, they're created by who's paying for care. And
Correct.
That's either an insurance provider, the government, who's an insurance provider, patients who pay on their own, right? Small, generally very small percentage, or providers acting as insurers or taking on the financial risk or owning the healthcare dollars. That's who has the incentive to care. No one else cares. They don't. No one else has the incentive to hear what we're saying, which is, I think, why we're speaking into this black hole of people should understand why we're so valuable. Well, but are you showing it to the right people? So show your value to the right people, right?
I said before, if you actually provide value as a physical therapist or a lawn care specialist,
That's right,
or a male person, doing that is half the equation. You have to show it too. You have to communicate it. And when you think you've reached maximum saturation, you're a tenth of the way there. You have to keep singing it from the rooftops. All right, for Dana Strauss, on her first appearance, but not last, because she's going to come back on the podcast, thanks for sharing.
Oh, so happy to be here. Thanks.
The PT Pinecast is a product of PT Pinecast LLC. It is hosted and produced by PT Pinecast CEO Jim McKay and CBO Sky Donovan from Marymount University. We talk PT, drink beer, and record it. This has been another pour from the PT Pinecast. The PT Pinecast is intended for educational purposes only. No clinical decision making should be based solely on one source. While care is taken to ensure accuracy, factual errors can be present. More on the show at ptpinecast.com.
The show today brought to you by the Academy of Orthopedic Physical Therapy, the leaders in orthopedic physical therapy. Find them online at orthopt.org. Now, with their current concepts of physical therapy in their 5th edition, it can help you prepare for that OCS examination. Find them online at orthopt.org. The Brooks Institute of Higher Learning gives you advanced post-professional education with 7 on-site PT residencies, including orthopedics, women's health, pediatrics, sports, and neurology, as well as an OMPT fellowship, all focused on experiential learning. Find out more at brooksihl.org.